I want to welcome everybody today to 30-Minute Thursdays, where we'll be talking about the throwing shoulder. Today, we're introducing three speakers, and I will be moderating. I'm Dr. Karen Sutton, and we're joined by Dr. Theodore Blaine and Dr. Taylor, as well as Debbie Jones, a physical therapist at HSS Westchester. Dr. Theodore Blaine is a sports medicine orthopedic surgeon at HSS Stanford, a former competitive athlete in swimming, football, and lacrosse. Dr. Blaine enjoys treating all athletic injuries of patients of all ages, and he's currently the team physician for Darien and Stanford High School football teams. Dr. Sam Taylor is a sports medicine orthopedic surgeon at HSS Stanford, former homecoming king at Greenwich High School, a former intercollegiate athlete, and Dr. Taylor has developed a unique understanding of the demands and anxieties faced by injured athletes at all levels. He currently serves as associate team physician for the New York Giants. We're also here welcoming Debbie Jones, who's a physical therapist at HSS Westchester. Her clinical interests include treating runners, overhead athletes, and concussions. Please note that in the chat function in Zoom, there'll be information for you to provide feedback, ask questions, and then we really do encourage questions throughout this broadcast, so feel free to write those in the chat section. So I'll hand it over to Dr. Blaine, who will be starting our presentation on the throwing shoulder.
Thank you, Karen. It's a pleasure to be here and with all this great faculty and panelists. As Karen gave the sort of background summary, this is a topic that's near and dear to my heart. I started my career at Columbia, had the opportunity when I was there to work with Dr. Steve Hirshon with the New York Yankees, so really got very interested in the throwing shoulder. And then since that time, I've worked with many collegiate athletes at Columbia, Brown, and then most recently at Yale. I've also had my own shoulder injuries. I've had 3 operations on my labrum as well as my rotator cuff. So again, a topic that's very near and dear to my heart, and I'm looking forward to the discussion today. So this is 30-Minute Thursdays, throwing shoulder. I thought I would start by talking a little bit about the throwing motion, because I think that's helpful to understand how we avoid injuries and then how we can treat them as well. So the throwing motion is shown here. It's 6 phases. Really, the first phase we see is the wind-up. There's really minimal shoulder force that occurs during this phase of throwing. That then progresses to early cocking phase, where the arm is brought up into an abducted position, and then leads to a late cocking phase, where now the arm is in a maximum external rotation position. In this position, that's where the rotator cuff muscles and tendons really kind of peak in their activity. And there's a lot of force that occurs, at least 1 times body weight or 650 newtons that is going through the shoulder in this phase of motion. Then we progress to the acceleration phase. So that's where the arm is then brought from this maximum external rotated position out until ball release. And in this phase of throwing, the angular momentum is huge. Really gets up to 7,000 rotations per second, so 7,000 degrees per second. So it's really a fast range of motion. And then the most violent phase of motion really is this deceleration phase, where all the muscles have to contract to slow this arm down after ball release. And the forces that happen to the shoulder through this this phase of throwing is about 1,000 newtons. So really large. And then you finish with the follow through where motion then stops. And just to show what this motion is like, this is Aroldis Chapman. Right now he's throwing a pitch at 105 miles an hour. I think his maximum ended up being 106 miles an hour. But you can see the tremendous motion that occurs at his shoulder and the tremendous force that occurs as a result of that. So it's important to think about, what are some of the key components of the throw, because it's not just the ball and the hand. So shoulder rotation is incredibly important. As we can see here, you need to have a huge amount of rotation to generate the wind-up so that then there can be the maximum amount of speed that comes out of this ball release. So shoulder rotation is quite important, and it's something that you really need to have to be a good thrower. But also very important is core strength. So what happens with the throw, the force is generated actually from the ground, then goes up through the lower extremity and then into the core. So the hip muscles and then the abdominal muscles are really important to be able to generate the force of the throw. Then it's transmitted to the shoulder blade and then to the shoulder. So in addition to the core strength, you also need to have the scapulothoracic joint, which is shown here, the shoulder blade, needs to be stable to allow the shoulder to rotate and to deliver the ball. So in this case, you can see that this shoulder blade is actually lifted up because these shoulder muscles are weak around the shoulder. And if that happens, that can actually create injuries and problems in throwers. So it's not only, you know, we talk a lot about the baseball pitch, but there are other types of throws that can lead to injuries. There's the football throw, so quarterback. This is a handball player here. Cricket throwers or cricket bowlers, water polo. There's, you know, a variety of different throws that can lead to problems. And the throws are not all the same. So if you look at this guy demonstrating a football throw or quarterback's throw, this throw is much more upright or erect and has less of a follow through than we see with a baseball throw. So the forces are a little bit less, but they're still substantial and can still lead to injury. In women's sports, there's also many different types of throws that are done. So softball throw is the one that's been the most studied, but also water polo players, javelin throwers, and a variety of different other sports can involve a throw. This is the one that's the most studied. This is the windmill pitch in softball. And that motion, also a little bit less force that's generated as compared to the baseball throw, but it's still substantial. If you look at the studies on this, the forces can be at least 1 times body weight as well, which is pretty close to what we see with a baseball throw. So again, you know, women's sports can lead to shoulder problems just as they can in men's. Karen and Debbie, do you have any thoughts about how women's throwers may be a little bit different than what we see in male throwers?
I think one of the benefits with the windmill throw is that deceleration phase that you talked about with baseball players. They do get a little bit of benefit from gravity to help slow them down a little bit. But I do think that sometimes you get a little bit of there's a little bit of a myth that softball player, it's a more natural throw, so they won't get hurt as often. But certainly what they may make up for in force, they make up for in volume. And so you certainly don't see any less injuries from them than you do your baseball players, maybe even more. But it may probably more comes from the shoulder than the elbow that you may see in baseball players.
And I know you're going to talk a little bit more about, you know, how you rehab people, you know, to try and prevent and also treat injuries later, and probably can talk to those issues as well.
The other thing we tend to see too in our female athletes, as we're talking about the various throwing, is predisposition to multi-directional instability, where we're thinking about the shoulder doesn't sit perfectly in the glenohumeral joint or the ball and socket of the shoulder, and the shoulder tends to have a bit more play. So where all the muscles called the periscapular muscles are trying to stabilize the shoulder, they have to work a little bit harder in some of our female athletes who may have looser or lax shoulder. So we do work closely with our physical therapists as well as our performance coaches to make sure we're emphasizing those periscapular muscles for some of those female athletes who may have a looser shoulder.
And I would just add one other thing to that Deb was kind of talking about and getting at here is, you know, when you particularly look at the softball pitchers throw, the windmill mechanics here, what you don't get there that you do get in some of the other overhead throwing mechanics is the kinds of stresses on the elbow itself. And so while the shoulder is still expected to perform in a very wide range of degrees of freedom and with power in similar fashions coming through to generate these rotational moments, the elbow doesn't necessarily see the same stress as it does in an overhead throw like you see in the water polo player, the javelin player. So the types of injuries can be a little bit different.
And Sam, what's your thoughts? I mean, you take care of the Giants and treat a lot of the football athletes. What are your thoughts about the incidents and the types of injuries that you see from the football throw? I mean, I know the throw's a little bit different. You really lead with your elbow, and it's really more in line than it would be with a baseball pitch. Are you seeing less injuries in quarterbacks than you would in a pitcher?
Yeah, I mean, we do tend to see less shoulder injuries in quarterbacks than we do in baseball players. I think that some of that has to do with repetition. Another part of that may have to do with the size and weight of the ball, which is thrown, that may help control the rotational moments in a different fashion than they do in baseball. And certainly the mechanics, as you mentioned, are different in kind of leading more with the elbow rather than this kind of far out type position here. I know we're not going to hammer on elbow stuff too much today and focus more on the shoulder. But one thing I would say is, in the news we read a lot about the Tommy John, the UCL reconstructions in the elbows of baseball players and javelin throwers, but we rarely ever hear about that in the football throwing athlete, the quarterbacks. And in fact, studies looking at those types of injuries in NFL quarterbacks show that the vast majority of people with those types of injuries do not undergo surgery to reconstruct it and actually do quite well. So every sport is a little bit different and has different demands, and needs to be thought about in a little bit of a different context.
And to emphasize your point, if you look at this is the quarterback's coach from Columbia, and you can see how really his elbow is right in line with his shoulder and his body. So probably much less force going through the elbow on the football throw than there would be with a baseball throw.
Mm-hmm.
So I thought what we do next, I'm just going to mention what structures we're talking about, and then if Dr. Taylor doesn't mind talking about some of the more common injuries, and then we can go into discussion. But just so everybody knows what structures are the problem in a throwing shoulder. So this is the labrum here, which really lines the shoulder joint, and it's where the biceps tendon comes off. So as the bicep tendon contracts, it can actually pull on that labrum and can create injury. And then the rotator cuff. So the rotator cuff is 4 muscles. This is the subscapularis muscle in the front. The supraspinatus muscle, which sits on top, also seen from the side here, is the one that's most commonly injured. And then there's the infraspinatus and the teres minor muscles that are in the back, and there are tendons, and those can be commonly injured in throwing. And these are the types of the injuries that we most commonly see. And if you don't mind, Sam, I'll hand it over to you here. And
yeah, sure. I'll hit on it just briefly so that we have a little bit of time to really hammer out some of the question and answer part of it. But one of the things that was, starting with the rotator cuff, which is a super important structure, as Dr. Blaine was talking about, that essentially kind of grabs the ball almost like a glove, and it's 4 tendons, a big one in the front, 2 up on the top, and 1 all the way in the back. And their job is really to help hold that ball centered in the socket. So as you're going through a motion, the ball stays centered in the socket and rotates appropriately. And so a good coordination of those rotator cuff muscles is extremely important to allow the shoulder to function through the range of motion that you need in order to effectively throw a ball. Now, rotator cuff tears in young throwing athletes, acute, real rotator cuff tears, are extremely uncommon and usually more related to a big traumatic incident rather than a repetitive throwing type situation. You can get irritation of the rotator cuff, some fraying of the rotator cuff, some partial tearing of the rotator cuff from repetitive type stresses on the shoulder.
Sam, could you go into that a little bit more? Sorry to interrupt, but I think, we get so many parents or baseball players coming in saying that they've been told they have a rotator cuff tear. Mm-hmm. And why, from our perspective, do we think that's such a big difference, rotator cuff tear versus the other diagnoses of rotator cuff that you mentioned?
Yeah, so so in the young and guys, feel free to disagree with me, because it'll make it more fun if we disagree. It's always more fun if we
I did warn Debbie about that.
All right, because I like to say, it's just
And we're going to address you as homecoming king.
Yeah, well, but then the person who is the real homecoming king is going to get upset, so we're just going to let that one slide. So, all right, so but with the rotator cuff itself, as the shoulder, the humeral head, the ball rotates. One of the things that we do see, as you see listed here, and I am going to address your comment, Karen, in a second, is what we call internal impingement. And so what that basically means is, as the ball rotates further towards the back, in kind of an adaptive mechanism to allow you to get this bigger external rotation to allow the arm to come further back, what happens sometimes in repetitive type situations is we start to get some partial tearing on the underside of the rotator cuff. And this is really an adaptive mechanism. And one of the big things that we found in our field over the last 20 years was, initially this was thought to be, oh my gosh, there's a rotator cuff tear, I must fix it. And in fact, fixing it often ends careers, because what that is we found is more of an adaptive change to allow the shoulder to get an even bigger range of motion to generate the kind of force that you need to throw a ball. And by fixing something like that, you tighten the shoulder up, you lose your motion, and you lose your velocity. So to what you were saying earlier, Karen, I would say that the rotator cuff is often a huge problem among the adolescent throwers, the young throwers, but it's not necessarily a rotator cuff tear that's the problem, but rather a kind of deconditioning event where all of the muscles that are involved in making the shoulder function through a range of motion kind of go out of whack. And it becomes our job as clinicians, as parents, as players, to help get that shoulder back in line. And that comes through things like rest, through other choosing to do other activities other than just year-round throwing, and then a number of things that I would turn over to Deb to talk about to help re-educate that rotator cuff and those muscles around the shoulder blade, which are extremely important. Deb?
Yeah, so I think we'll talk a little bit later on about some the exact things that you have to do, but that's working that cuff is basically one of the most important things that you can do, as well as Dr. Sutton mentioned earlier, some of the intrascapular and periscapular muscles, getting that shoulder blade basically in proper position as well.
I think just to emphasize some of the points that Sam was making, and I'm sorry, Sam, I have to agree with you. I apologize for that, but yeah, I mean, you almost are going to have, there's this thing called the shoulder paradox, right, or thrower's paradox, where like you need to have a very loose or lax shoulder, and almost an unstable shoulder, to get your arm into that extreme external rotation position and cocking to be able to generate force. So you need to get your arm in a position that's going to pinch the rotator cuff. I mean, it's just going to happen. So, you need that, but at the same time, that instability or that motion then can cause the injury. So it really is a paradox. But, you don't want to take away that motion thinking you're going to make patients better. You actually will make the thrower worse if you either repair that rotator cuff or tighten that shoulder. So I think it's a really important point.
One of the things that I would also say, Karen was talking about the muscles around the shoulder blade being extremely important, and oftentimes what happens in these throwers is there's some event that causes a decompensation. So it doesn't even have to be a big thing, but you get some kind of painful event that basically sets the whole cycle out of whack, and then the rotator cuff starts to function without the kind of synchrony that it normally does, and then the muscles around the shoulder blade aren't doing their job, and then one thing leads to another, and all of a sudden you get caught in the cycle of more pain, weakness, dysfunction, and you're just kind of cycling around and around. And all those muscles around the shoulder blade, which they're extremely important and extremely complex, and I can't even figure them out still to this day exactly how it all works.
How many are there, Sam?
There are so many, Dr. Sutton. There's lots of them. But one of the things that we'll often see in these throwers, like there was a picture earlier that Ted had up, or that we had up, where the kind of shoulder blade was winging a little bit. I don't know if we can go back to that. But oftentimes what happens with these adolescent kids, like this picture here, is they come in and they say, oh, my shoulder's so weak, it's so weak. And they're raising their arm, and you see the shoulder blade just kind of wing out like this, because the muscles around the shoulder blade aren't controlling that shoulder blade. And that control of that shoulder blade is what everything else around the shoulder is based on, the functioning and stability of that shoulder blade. And so what's often impressive in an exam room is how you will test somebody's strength and, oh my gosh, they have no rotator cuff strength at all. But if you stabilize their shoulder blade, you just manually hold their shoulder blade against their chest wall, for the parents, all of a sudden the rotator cuff is rock solid strong. And so it's a very interesting way to demonstrate how important those muscles are to the whole throwing motion.
And without any pun intended, I would throw it over to Debbie to educate Sam on those 17 muscles that surround the scapula. And if you could talk a little bit about...
I'm going to go through some of these injuries, if you don't mind, Karen, and go right to where Debbie's going to tell us how to...
Oh, sure. Perfect.
Because we just don't have enough time in 30 minutes to go over the injuries in detail. But yeah, why don't we throw it to Deb and have her tell us how to prevent these problems.
Right, and just a quick point about what Dr. Taylor was saying about that pattern that throwers get into. There's often that pressure to keep pushing through that pain and keep pitching and throwing through that pain, and I feel like the longer that they go, the harder it is to pull them out of that pattern that they end up developing. So, after they've seen you guys, whether you end up operating on them or injecting them or whatever ends up happening to get them to us, pulling them out of that pattern that they've developed, the longer that they've been in it, the harder it is to get them out of it. So, emphasizing the idea of, continuing to pitch through and push through that pain is just, it's so important to not do that. So a good strengthening program, we've hammered on the idea of rotator cuff, rotator cuff, rotator cuff. The serratus anterior is the primary muscle that keeps that shoulder blade from lifting off the back of the rib cage and doing that neat little trick of winging out like that. I get a lot of kids that come and say, look at this neat trick I can do. And that's not a neat trick. Like that's basically your shoulder being weak. So your interscapular muscles, those muscles in between your shoulder blades, your middle and lower traps, your rhomboids. Another important point is that it's not just about, like, I'm going to just get one plane of motion. Like, if you're a thrower, you need to be getting up here, you need to be getting here, you need to be getting down here. You need to be getting multiple angles of your serratus. So making sure that you're hitting all of these angles that you're ultimately going to need to be in. A nice little program that you can find online is the Throwers 10 or the Advanced Throwers 10. And so then beyond your arm care program is on the next slide. So if you hit the next slide.
Oh, I'm sorry. I'm not the best manager here. A couple of things going. Okay, there you go.
Is the trunk stabilization. And so as we were talking about, Dr. Blaine showed earlier that it's about that entire kinetic chain. And so the power comes from the hips and the glutes and transfers through the trunk and then into the arm. And so if you don't have that entire chain taken care of, then you're going to lose something, and that's ultimately going to transfer too much stress to the arm. So making sure that you hit that trunk, that you hit your hips and your glutes. I'll sell this on the idea that it's not just about injury prevention. but that, you know, if you draw your power from your throw through your hips and your glutes. So if the stronger that you can get those is a better motor for your arm. But then the injury prevention part of that is that if you don't strengthen that part of the power, then you're going to try to drive too much through your arm, and it's all going to come through your arm. You spend a lot of time on one leg in your throw, so you need to do some single leg activities, and then just, you know, you got to hit your overall fitness. So some biking and jogging. I don't think pitchers should, you know, be running marathons or anything, but they, you know, they need to be overall. You need to be overall fit.
All right, so I'm going to turn it back over to Dr. Sutton to manage discussion.
Sure. So just to note, we do have attendees who were former baseball pitchers. So I think focusing on that, one thing that I'd like to discuss is pitch count in our youth, high school, college, and professional athletes. And if anybody wants to comment on how pitch count may not be specifically relevant as we get back from the pandemic and are resuming some sports. If you want to read my mind, basically, I'm a little worried that the exact pitch count may be too high right now as athletes are maybe deconditioned.
Yeah, I think just, you know, just to make a comment on like, what is the pitch count? I'll have to look it up, you know, it all varies based on the age of the patient or the age of the thrower and their activity level. But in general, I kind of think about the rule of eights. So really people should be pitching for about 8 months a year. They probably need 4 months of rest in between. And about 80 pitches a game is kind of think about 80 pitches a game, and the faster pitches are more of a problem. So if you're about 85 miles an hour, that's usually an issue. So just some general terms that makes it easier to remember.
Ed, what do you think about adolescents throwing curveballs? You know, that's kind of one of the big things that people ask frequently.
I think, you know, a long time ago, we thought that was a really bad idea. And I think the latest research has said that it really, honestly, the breaking balls don't really put any more force through the arm and shoulder than fastballs. In fact, fastballs, probably because they generate more speed, put more through. I don't necessarily think that, you know, your 11 and 12-year-olds need to be working on those. But I don't necessarily think that they shouldn't either.
Mm-hmm. Yeah, I think there has been some change in the thinking on that, but you know, for a while we were thinking that adolescents shouldn't throw any curveballs. I think it's changed a little bit, but you know, just common sense. You got to believe that there is a lot of force with the curveballs. So.
Sam, one other question that comes up a lot are subluxations versus dislocations. I know you have to diagnose those really quickly too, especially taking care of the giants. How would you classify a subluxation versus a dislocation? Mainly talking about a first time.
Yeah, so I mean, so that's so it's interesting because when we talk about instability of the shoulder, I think that you can think about it in a few different ways. And so you've got your traumatic dislocations, which in the throwing type athlete, a baseball or softball player, for example, may come diving largely in a big traumatic event like diving for a ball in the outfield or a head first slide into a base. Versus the other kind of instability is more of what we call a micro instability type pattern, where through repetition, the stretch, you know, over and over on the tissues in the front part of the shoulder can lead to instability of the ball and socket joint, so that it's not necessarily dislocating, but there's some micro motion there that results in things not rotating and firing the way that they should. So I think that when we think about instability, you kind of think two different buckets. So you've got your thrower's instability, a micro instability type pattern, which is a lot more of a challenge to diagnose and potentially treat versus the traumatic instability or dislocation.
And just to, you know, echo on that point, I think, like we said before, being unstable for a thrower is often a good thing. You know, often we'll tell people come in the office, they say, oh, you know, I'm really lax, I got really loose joints. And I say, well, you must be a good athlete. So it actually is, I mean, it can be a problem if it's too much, if the ball actually dislocates, but if there's a lot of motion and there's micro instability, that may actually be a good thing.
There was one question that came in from a guest about what about frozen shoulder as an early sign of dislocation? So I think of those in two different genres, but Sam, do you want to touch base on frozen shoulder versus dislocation?
Well, I mean, they're kind of two kind of polar ends of the spectrum. Whereas, when we think about a frozen shoulder, you're thinking about something that is essentially too stiff versus instability, which is something where it's too loose. Now, it is true that an instability event or a shoulder that's not functioning correctly can lead to irritation that causes a stiff shoulder. But in general, they're two kind of very separate camps, at least in my mind, the way that I think about it.
The only time where I've seen those concepts converge is there's some patients who may be developing some arthritis in the shoulder, and those patients actually they're stiff, but they feel unstable. So
Right.
That's usually the category that I see where they're coming in with both problems.
Right.
And then Debbie, I'll send it over to you too in terms of when a lot of our athletes now are training at home during this coronavirus pandemic, are there specific exercises that you would really emphasize them avoiding during this time?
I don't necessarily think that there's anything that I would have them avoid. I think that there's, I would more so when they start to get back into things, and it's just, jumping back into their activities with both feet, so, a base shouldn't jump right on the mound day one. So almost everybody has to think about this like they're coming out of an off season, or they're coming off of a rehab stint, or there needs to be a gradual progression back into everything. So just, basically taking it slow and looking at their overall workload so that, 3 months from now, we're not seeing, a ton of tendonitis and overuse injuries. Not that we don't appreciate the business, but,
Yeah, I agree. I think it's going to be a challenging time. And I just want to thank all of our speakers today. This was a great topic. And, I think a lot of us could talk forever on it. But I'd like everybody to tune in next week for our topic on the weight room, avoiding back and other common injuries. So thank you very much to all of our guests. And we've got a lot of great information on the throwing shoulder here in this topic.
Everybody.
Thanks, everyone.